evening, everyone. Welcome to session 10 of the SCTS Foundation Doctor Academy National Teaching Programme. It's the halfway mark. I can't quite believe it myself, and it's my absolute pleasure to introduce this evening's speaker. Mr Rathinam is a consultant thoracic surgeon with University Hospitals Leicester. He's a chair of the Intercollegiate Specialty Exam Board, Communications Secretary of the SCTS, as well as chair of the Cardiothoracic Specialty Surgical Board of the Royal College of Surgeons of Edinburgh. Tonight he'll be talking to us about pneumothorax and haemothorax. Without further ado, over to you, Mr. Rathinam.
Thanks, Hanad. It's indeed a pleasure to join all of you. Can you hear me okay?
Yes, perfect.
Okay. Please feel free to interrupt at any given point if you need any clarity, and I'll try to make this as interactive as possible, but within the time constraints. So what we'll try to do is to just have an overview of the anatomy, applied physiology, the causes of pneumothorax and haemothorax, the management, the algorithms and guidelines in this next 40 minutes to an hour. Can somebody tell me what's wrong in this chest X-ray? Feel free to unmute and switch your camera on. What's wrong with this chest X-ray? Is it a normal chest X-ray?
We have some people commenting. Emma Law is saying tension pneumothorax, and Ogulkan is saying rib fractures on the left side, tracheal deviation to the right. So
should this chest X-ray be done? It shouldn't, isn't it? Because you have a tension pneumothorax, you have multiple rib fractures, there's an endotracheal tube in there. So tension pneumothorax is a clinical diagnosis, not a radiological diagnosis. So technically this shouldn't have been done, and they should have had a needle into the chest, right? So today I've been asked to cover pneumothorax and haemothorax, and this almost covers both aspects, as it. Rib fractures lead to haemothorax and the like. So just to go back to anatomy, so the pleural space is a potential space which has a parietal pleura on the chest wall surface and a visceral pleura which is applied onto the lung. And anything which gets in between the two leads to a collection of fluid, which is a pleural effusion. If it is blood, it is haemothorax, and air, it is a pneumothorax. Now, you need to understand the perspective. The cause could be from the lung per se, it could be from the chest wall, it could be from any of the deeper structures, which include the tracheobronchial tree, and in terms of haemothorax from the heart and the like. So always keep an open mind, and remember the chest is a three-dimensional structure, and your imaging and investigation, depending on what you do, may give you a different perception. So if you have an erect film, you'll have a pneumothorax at the top. If the patient's lying down, the pneumothorax may be actually basal or lateral. So that's your pleural space in the black, and you have the tracheobronchial tree, which can then lead into the lungs. So the lung ruptures with a bleb or blister can cause pneumothorax. If there is airway rupture, it can cause a pneumothorax. Likewise, esophagus, which carries the food bolus from the cricopharynx to the stomach, if it perforates, can cause pneumothorax and pleural effusion. Likewise, any injury to the chest wall vessels with a rib fracture can cause pneumothorax, stabs, and injuries to the central blood vessels. So you should have an open mind on how you deal with these. So thoracic trauma is not new. So there is documented evidence by the Egyptians about chest injury. Homer's documented blunt and penetrating injury. Likewise, it's the military invasions and all of those things in the medieval Europe which defined thoracic trauma and the management. And as you can see, the penetrating injuries have been gained largely through military experience. And the mortality for penetrating injuries during the First World War was 56%, which has now come down to 3%. I'm sure it is much less if you take stock once the war is over in the Russo-Ukrainian conflict. But 76% of them can be just managed with a chest drain. You do not need a thoracic surgeon or diving into somebody's chest to fix these. So what is the basic pathology of thoracic trauma? So it depends on the mechanism of the injury which causes the hemothorax or the pneumothorax. It could be blunt, road traffic accident, hitting yourself with the steering wheel, penetrating, stab, gunshot, or blast in today's world. If there is shrapnel or whatever, that can again cause damage. But whichever way the trauma is, all it does is it causes fractures, flail chest. The deceleration can cause tears and torsion, and congestion and compression can cause rupture. So all of these can manifest as pneumothorax, contusion, and the rest of them. Penetrating trauma, again, the same, could be stab or impalement injuries when you say hello to the fence, when you're thrown off a horse or a bike, gunshots. But irrespective of what the cause is, you still end up with the same manifestations on the patient. This lady was stabbed multiple times by her boyfriend. Interestingly, she didn't end up with a hemothorax or a pneumothorax. They always subcutaneous injury because the damage depends on the depth, the site, the direction, and the cleanliness of the wound. Likewise, blast again causes both secondary and primary damage because it's the blast wave itself, but also the various shrapnel and the missiles which come off the blast. But the fundamental thing is the impact is the same irrespective of what the injury is. So you have loss of mechanics, you have ventilation perfusion mismatch because the area in question is not getting any oxygen or blood. The patient's in pain with your fractures and hemothoraces, hypovolemia, which leads to hypercarbia and acidosis. So post-traumatic respiratory failure is quite quick with hemothoraces or large pneumothoraces. The chest, you can look at it as central chest and lateral chest. It is the lateral chest injuries which cause pneumothoraces, but your central chest injuries can cause massive hemothorax. Always have an open mind depending on the mechanism of injury and how the patient manifests. And also bear in mind, you have intrathoracic abdominal contents, which can also be the culprits. So this, we've come back to the same image. So pneumothoraces in a traumatic setting can be open, closed, or tension. Air accumulates in the pleural space because the lung is a balloon inside a box, and as air gets in, it squeezes the lung away, and it reduces oxygenation and carbon dioxide exchange. And when it cannot get out any further, it starts squeezing on the mediastinum, and that's when, do you actually see the cursor moving?
Yes.
Okay, so that's when you end up having the mediastinal shift and the rest. Now, in a trauma setting, you end up with a massive hemothorax. So that's when you have accumulation of blood, as you can see in this image on the right side. And the chest can accumulate up to 3,000 milliliters of blood easily, and the patient can go into hypovolemic shock and respiratory compromise. And massive hemothorax is a condition with significantly high mortality and morbidity. Massive hemothorax patients tend to be in what we call as a metastable condition. What do we mean by metastable? So the patient's hypovolemic, then bleeding stops, you then fluid resuscitate them, blood pressure goes up, they start bleeding. So it's a vicious cycle. So bear in mind, if the patient who has sustained multiple fractures or stabs, who goes through the cycle, then you have to have an open mind that there is something more sinister which is going inside the chest, and it's probably not just bleeding from the chest wall or rib fractures. You have to optimize and manage them early. So if this happened outside in the field, you have to make a decision. Are you going to scoop and run, or are you going to stay and play? Now, you may have to stay and play in trauma settings in two status. One is a sucking chest wound. So if they've had loss of the chest wall and that's caused an open pneumothorax, you will have to fix it on the site. Likewise, tension pneumothorax has to be decompressed. We don't do much for hemothorax, but pericardial tamponade, again, it's out with this topic, but that again has to be managed at the field. If not, your patient won't make it to the hospital. So it could be either traumatic, it could be stabs, whatever. But if you have an open pneumothorax, you need, because you've lost the physiological negative space. And that's what's going to kill the patient, because air will get into the chest and squeeze everything because it's positive pressure. So what you do is a three-way dressing. So you take a swab, put it on the wound, and you adhere it on three sides, allowing air to get out on the fourth area. So essentially, you're closing an open pneumothorax into a closed pneumothorax, but with a vent so that air gets out. Can you see that? So that's your hole. You've strapped it on three sides, so air gets out, but it also acts as a one-way valve to prevent it coming in. The other thing which you can do is custom-made chest seals. So this is Asherman's chest seal. The under surface has got an adhesive. This has got an opening with a one-way ductile valve. So if you stick this on the stab area, or where you have a small hole in the chest, it'll let the air come out and you can safely bring the patient to the hospital. But pre-hospital management teams and ambulance crews can safely put a chest drain or even do thoracostomies to get the patient airlifted. The HEMS teams usually do a thoracostomy rather than put a chest drain if the patient's tensioning. Clearly, the rest is your ATLS, primary, secondary survey. I won't dwell into it. When you come to investigations, always have a high index of suspicion. When you have a hemothorax, what else is going on? So your primary chest x-rays, contrast CTs. Today, everybody gets a trauma contrast CT and where indicated an angiograph. So that's a widened mediastinum. In this case, you do not have a hemothorax. And you can see in the contrast CT, there is suspicious aortic disruption. So if this patient bleeds, you're not going to fix them in the ED. So these are things to have an open mind, and the contrast imaging does show that there's a pseudoaneurysm with a leak there. Yeah? So the various interventions you can do, the first and foremost is chest drain. In civilian practice, up to 85% of major hemothoraces can be managed with a chest drain. 15% may require a further intervention. So that's your standard chest drain, which is an underwater seal. For those of you who have not worked in a thoracic unit or have not seen the chest drain, so this has a water column which acts as a one-way valve. So blood and air get out of the chest, but they will not go back into the chest. So it acts as a one-way siphon valve mechanism. Clearly, traumatic patients require adequate pain relief, oxygen, physiotherapy, and antibiotics. So how do you put a chest drain? So your ATLS principles and your standard surgical practice for a traumatic chest drain is to get a drain in the triangle of safety. So if the patient lying down, your triangle is marked by the lateral edge of the pec major muscle, the lateral edge of the latissimus dorsi muscle, and then the fifth intercostal space, and you have the base of the axilla. So this is chosen because then if you go in, you will avoid any inadvertent injury to your intrathoracic abdominal contents like stomach or the liver on the right side. More importantly, you will not hit the heart. So all of that is taken into consideration. It's a surgical cut down followed by blunt dissection with a finger sweep. So you give loads of local anesthesia, make a patient comfortable, you make a skin incision, and then you use a Roberts forceps or a blunt forceps to dissect. You work on the superior aspect of the inferior rib. And the reason for that is you have the intercostal bundle which runs under each of the rib. So your Roberts hugs the superior aspect of the rib. You then finger dissect as you go, and once you reach the pleura, there's going to be a gush of air or blood. Once you've done that, then you advance a drain under guidance of a Roberts. Back in the day, when I was a junior, we used to have drains with trocars, which were easy to put, but equally, well, they also came with the collateral damage of injury to the other organs due to the nature of the dissection. How many of you have put a chest drain or seen a chest drain being inserted? None? Nobody? There's the chat box. Oh dear.
We have one person commenting they have.
So how easy or difficult was it? Aziz or Rehab, do you want to unmute and tell us what your experience was?
Hello. Can you hear me?
Yeah.
Yeah, so I observed actually 2 chest drains and I assisted in one. When it looks easy, but when you do it or you assist in it, it's not that easy. So it's just the feeling that you might puncture something or just go deeper than you should.
Well, that's the key, and that's one of the reasons why I asked you that. So although you use a sharp Roberts like instrument to go in, once you've gone to the superior aspect of the rib, the 2 things you need to do is give a little bit more local. Why is it typing whatever I'm saying? I've done something. Can you guys see what it is typing, what I'm saying?
Yeah, I can. I thought you were being innovative there.
I
wasn't
don't
quite
know.
sure what
I don't
happened.
know how it's happened.
It's quite accurate as well.
Oh dear. Okay. Well, you'll have to bear with me. I don't know how that's happened. So you get subtitles to what I say, people. So the key is, so if your Roberts is like this, and once you've gone to the intercostal space, so that's where you are, your finger dissected and you're feeling the pleural space, the common practice is to hold your Roberts like that and try to show it in. Please don't do that. So hold your Roberts very close, just about an inch, and then advance. And the reason for that is if you do so, then you will not go straight deep diving into the chest and cause damage to things like your heart or your liver. I'm quite impressed with the subtitles. It is actually quite good.
Yeah.
Well, I've never seen that, but the chat box came and I thought I was going to look into the chat of what you guys were saying, and this has happened. Anyway, is there an indication for surgery in hemothorax? When do you intervene and what would you do? Do any of you know? So you put a chest drain, blood's come out. When will you intervene? What are the indications for surgery? So the indication is twofold. One is persistent bleed. Second is when you have something which is going on inside the chest. So it can be life-saving operations where it is damage control. So you're called to the ED, they say, look, this guy came, we put a drain, he's bleeding like nobody's business. So there, it's a massive hemothorax where you have to damage control. So that's where you would open a chest in emergency department. The second cohort is early surgery for major injuries. So these, you put a drain, but they continue to bleed. Usually more than 2 liters, you think there is something which has happened. The second cohort is when they persistently continue to bleed. And the third cohort is surgery for late sequelae of chest trauma, where you have collected infection, empyema, or foreign bodies which are inside the chest. So emergency thoracotomy is damage control. So you have a chest full of blood, you're going in and you want to stop the bleeding first and then find out what it is to fix. So once you're in, it's going to be just horsing depending on where the injury is, particularly with stab injuries. So there, what you do you do, we'll come to how you get into the chest in a second. You go in and you try to stop the bleeding by squeezing the hilum. So there are three things you can do. You can just free up the inferior pulmonary ligament and twist the lung on its own. So essentially you're rotating it by 90 degrees. So what that does, can you see my cursor move?
Yeah.
So what that does is essentially pinch this vasculature and stop the bleeding. That allows you to clear the blood in the chest and then see where the damage is. The second thing you can do is you can put a sling. So the sling goes around the pulmonary hilum, you pull it out and you snug the hilum. So essentially you're stopping all blood coming into that lung and you stop the blood. And the third is you take a big vascular clamp and clamp there. So this is major hemorrhage emergency. You just have to deal with it there and then. However, the other cohort is the patient's reasonably stable, but then they continue to deteriorate. More than 2 liters in the first 4 hours, more than 200 mils per hour for the first 4 hours, 400 mils of dump. And when they also have other things like a traumatic thoracotomy, wherein part of the chest wall is gone and other things. So that is an indication for you to take the patient's data. So how do you get into the chest? So the two ways you get into the chest in an emergency situation is an anterolateral thoracotomy. So the patient's lying down. The only thing which you need is your assistant and a scalpel, and you will be inside the chest in no time. So you make an incision, submammary, use the pectoral groove, go in. But the key you have to remember is you will have to go higher to get into the chest. You want to get into the chest with the fourth or the fifth intercostal space. If you go by the pectoral groove and go straight down, you'll be in the sixth or the seventh intercostal space staring at the diaphragm. So this gives you ready access to the pericardium. So if there is tamponade, you can deal with it. If there's bleeding, you can deal with it. You can massage the heart if you need to resuscitate, and you can deal with your hemothorax. If need be, all you need is a big scissors, and you can cut across the sternum. If you have a giggly saw, fine, but if not, just cut across with the sternum and then make a similar incision on the other side, and you end up with what we call as the clamshell incision. Yeah, so this one gives you access all the way from the aortic arch to the diaphragm, the lungs, and you can see what it is and then deal with it. So these are all acute emergencies, and sometimes it is done by emergency physicians, especially in a major trauma center, and then they'll call you to say, look, we've done this, can you come and help us out? Or they would say, look, there is a stab, peri-arrest coming in, get to the ED, we may have to crack open. And once you're in, you have to decide what is a definitive step, damage control steps. So if there is a laceration of the lung which is bleeding and causing the hemothorax, you can just suture it. If there is a stab or a bullet which has formed a tract in the lung, you have to do a tractotomy. Sometimes you can just take it out as a wedge resection. So if there is a damage in the lung which is bleeding and leaking air, pick it up, staple, and take it out. Sometimes you may have to do major things like lobectomy or pneumonectomy and repair vascular tracheobronchial injuries as appropriate. So this, as you can see, is a nice small laceration on the lung. Can you see that? So this is a lateral thoracotomy. You have the heart there. That's the lung, is laceration. So you could easily put a couple of sutures and stop that. Alternatively, you can pick this up with a duval and then fire a staple under it, and you can remove that laceration. This is where you have a tract. So the stab has gone right through the lung to the other side, wherein you put a stapler, staple and open up the lung, and then oversew the damaged part. And you have to have stringent follow-up for these hemothorax patients because they will have other things. And depending on how things are, whether it is acute or whether it is rapidly done on the roadside, sometimes you may end up doing a layered closure properly if it's done in theta septic, or if it's In a ED, you may just want to do mask closure and revisit things and follow them up because they may require further specialist thoracic or cardiac input. And the patient may present to you acutely, but sometimes as a thoracic surgeon, you may end up getting involved at a delayed stage. So the patient comes with a traumatic pneumothorax, they put a drain, but there's persistent air leak. So you will have to go in to see what's leaking and stop it. The hemothorax, which is retained, which is managed with the chest drain, may now have got infected or will have more clots. So therein you may have to go in and evacuate it. And finally, retained foreign bodies is where a thoracic surgeon is called in to help. And this is, as you can see, there's a stab with a glass piece which is impaled onto the diaphragm. Can you see that? So
yeah,
this patient ended up having a thoracoscopic removal of this, all the while being prepared to convert it into a thoracotomy or even a thoracolaparotomy. So you always have to think one step ahead of what can go wrong. So if you take into consideration a traumatic hemothorax, pneumothorax, a large proportion of them can readily and easily be managed with a chest drain. A small proportion will require a thoracic or a cardiothoracic surgical input, and that depends on the spectrum of the injury as to what you do with varying morbidity and mortality. So who is this and why are we having him in our talk?
we've got a comment in the chat from Charlos Lenek.
Yes, so why is Lenek relevant to our discussion today? So Lenek is relevant because Lenek is the first one who described pneumothorax. So it was one of his trainees who came up with the concept, and he is the first one to describe pneumothorax. So pneumothorax, if we stay away from the traumatic setting, which is primary pneumothorax, it's a common condition which respiratory physicians deal with. And the male to female ratio is about 2.1 to 1. And we have about 8,000 admissions for this in the UK. And an average unit like ours do anything between 50 to 75 cases of pneumothorax. So that's the prevalence of pneumothorax. And you can see there is definitely a male preponderance as per this study which looked at epidemiology of pneumothorax, and that varies with the age groups as well. So this is an interesting study which looked at 59,000 and odd patients, hospital stays of 42 or nearly 43,000 patients. And the annual rate was around 22%. And women to men in this study was almost 1:3, so it was more male preponderant. The mean age was higher in the women, but the important thing is 25% of them ended up having a surgical procedure to fix their primary pneumothorax. But the management varied. So rehospitalization was more in the women. And in the age group, for instance, if you took the 30 to less than 30 age group, the hospitalization versus medicine, there was not much difference between the men and the women. But as the age increased in the 30 to 49 age group, surgery rehospitalization were more frequent in women than in men. And if you take the 50 to 60, the surgical procedures and rehospitalization again were more in men than in women. So there is something which is different according to this epidemiological study. And you can classify, if you take the traumatic pneumothorax out, you classify them as primary or secondary. Primary is when it happens de novo with no underlying medical condition. It's almost an oxymoron because if there wasn't an underlying condition in the lung, they wouldn't have ended up with a pneumothorax in the first place. But that's what we call, when it's a fit young person who comes with pneumothorax, it's primary. But if it is an older person with a smoking history, emphysema, COPD, then it's a secondary pneumothorax. Primary is mostly associated with smokers, but more importantly, tall, thin, lanky people. And the hypothesis is because they are tall, the apices don't get the same amount of blood supply, so they are more weaker and they form blebs, but it has not been scientifically proven. It's just a hypothesis. Smoking is related, and the BTS guidelines ask the physicians to refer them if there's persistent air leak after 3 to 5 days. The secondary pneumothorax setting requires extra care because underlying lungs are worse. And there can be other causes which cause pneumothorax. You can have tuberculosis, trauma, we discussed it earlier on, iatrogenic central line, esophagoscopy, bronchoscopy, esophageal rupture, catamenial pneumothorax. So in women of childbearing age group, there can be pneumothorax which occurs cyclically during ovulation time. And the reason for that is when the ovaries release the ovum, a bit of air gets out. And if they have holes in the diaphragm, that gets into the chest. And lymphangioliomyomatosis is another condition which can form blisters on the lung, which can cause pneumothorax. So always beware that what you may think as pneumothorax could be a secondary lung with large bullet. So can you see how damaged this lung is? With lots of holes, in fact, it is protruding into the other side. And if you look at it, there's paucity of any vasculature or air. So if you did a chest X-ray in this patient, it will give you the impression of a pneumothorax. And if you stick a drain there, you're causing havoc, not treating the patient. So the size dictates what we do, and you use your cardiorespiratory ratio and what size the drain is, and if it's greater than 2 centimeters, you start thinking of intervention. And there are algorithms which allow you to calculate the size of the collapsed lung. In today's world, in addition to this, you also have the cross-sectional imaging, which helps you to assess if it is a big or small pneumothorax. So do you aspirate? Do you conservatively manage? Do you put a drain? If you put a drain, is it a surgical drain? Is it a 24 or a 28 French? And do we temporize them before doing other things? Or on varied? It depends on units and where the patient first presents. Excuse me. The chest physicians are the gatekeepers, and they most often than not would aspirate on the first instance. If not, put a Seldinger drain. Whereas if it is secondary, they are more likely needing a thoracic intervention. So we always tell our physicians to talk to us early. And then comes the question of, do you put the drain on suction or not on suction? So if there's failure of expansion, you will put negative suction on the drain with an underwater seal or a digital drain. We'll come to that later. And that will allow the lung to re-expand. And if there's persistent air leak, then we intervene surgically. If the patient's comorbidities are too much, then you may have to manage them conservatively and consider alternatives like a blood pleurodesis or a talc pleurodesis. So this is what most chest physicians will deal with, will use to deal with a pneumothorax if it is a large one. So this is a Seldinger chest drain. So you have a needle, they insert the needle into the chest after the image confirmation, aspirate to let air out, and then advance a guide wire which goes into the chest. So it's a blunt guide wire which goes into the chest. Then you put the drain over it, a dilator, and then pass the drain on. Whereas if it was surgical, then we would do what we described earlier, finger dissection, finger sweep, and put a 24 to 28 size drain. I've showed you how it is usually managed underwater seal, but what has come into vogue is digital drains. So these are topaz drains which have suction in the unit, which is batteries operated, and it gives you the volume of air coming out and what is it set at. So this is in centimeters of water. In the UK, we use kilopascal. So usually it is 0.8 kilopascal, which is no suction, or -2 kilopascal, which is suction, which is equivalent of a -5 kilopascal on the wall. This is the other option, wherein if the lung stays up but there's still persistent leak, you can put them on a flutter bag. There is a ductile valve, one-way valve here, so air will come out, blood will come out, but nothing will go back. More and more physicians are using smaller vents. So in the Seldinger drain, you have to put a drain in that is connected to a drain bag. Whereas this one, similar principle, but it has a small canister with a one-way valve attached. So the air comes out, fluid comes out, and the patient can be sent home. So it is ambulatory respiratory care. So they do not need to be admitted like how they would be with a chest drain. So things are constantly evolving. What would you do with this patient? Do nothing? Aspirate, put a drain, vent? Which side would you intervene?
Dennis says fit in a chest drain.
Okay. And that's what you would cost. So that actually is a large bulla. Can you see the streaks of lung? Yeah?
Yeah.
So the lower lobe is collapsed, the upper lobe's got a large bulla, and putting in a chest drain would have caused massive air leak. So always get a cross-sectional imaging if the patient is over 30 years old, so that you know where you're going to go in if the patient is stable. I would urge you all to read this at length. This is the British Thoracic Surgical Guidelines, which is getting updated now, but this one is from the 2010. So if the patient comes with a spontaneous pneumothorax, if bilateral or hemodynamically unstable, proceed to a chest drain. If they're less than 50, significant smoking history, then you're treating it as a secondary pneumothorax. If it's greater than 2 centimeters or breathless, chest drain. If it is not, aspirate and then follow up. If it doesn't improve, again go back. So on the contrary, if it's a younger patient and if it is greater than 2, aspirate. If it succeeds, fine. If not, consider discharge and review. So that's the algorithm. But if it is persistent and they put a drain and it's not settling, then they will come to us. Now, in the UK, we do not intervene for a pneumothorax on its first presentation. There is a 1 in 3 chance they will end up with a second episode of primary spontaneous pneumothorax. So that's when a referral is made to the surgeons. And that's again an ongoing debate, because if you have a tire puncture and QuickFit tell you there's a 1 in 3 chance it'll go, you will want the tire fixed. You wouldn't hit the motorways with that. Yet, the current practice in the UK is we only intervene on the second episode. And there's also variation in how people intervene. So this was a survey of all the intensivists in terms of pneumothorax, and the intervention varied across the different countries. So that's Americans, that's UK, and then this is the survey. So this is what the guidelines recommend, and this is what was happening in real world. People tended to do more than what the guidelines referred in the intensive care setting. Always have an open mind for a giant bulla. It can be mistaken for a pneumothorax. The other big problem you will have with secondary pneumothorax is patients will end up with this. So this is surgical emphysema, where air gets out of the chest and it creeps under the skin. So the drain may have got blocked off, the suction may have stopped, or the patient may have developed a big rupture of bulla. They just blow up like Michelin man or woman in front of you. Their voice becomes very shrill, and they can go all the way from the scalp to the scrotum in no time. So be mindful of this and you need to remedy. So that's a CT scan. So there is an underlying pneumothorax, and as you can see, there is gross surgical emphysema. So this is a recent survey which Naj Rahman did from Oxford, looking at what was the contemporaneous practice of the UK chest physicians. So 50% would manage a large primary spontaneous pneumothorax with minimal symptoms conservatively. And this is a changing trend, and I'll come in a second as to why this trend has changed. 64% will use suction if there is a pneumothorax, which is not resolving greater than 2 days. 15% will clamp the drain before taking it out. They want to be absolutely certain that the patient will not need the drain again. Although the NICE guidelines recommends digital suction, which is the Thorax drain, which I showed you earlier, it is not in prevalence in the practice. So as you can see, there is variation. So if there's minimal symptoms, most would just manage it conservatively. On the contrary, if it's a large pneumothorax, especially if it is secondary spontaneous pneumothorax, they would have a chest drain and a small proportion with ambulatory systems. And this gives you a beautiful, colorful illustration. So if there's minimal symptoms, most often ambulatory device or conservative management. But as it goes to ongoing symptoms and they're symptomatic, they tend to have aspirations and drainage. So this is the algorithm of a study which has triggered the way things have changed. So this is the PSP trial from Australia and New Zealand, wherein they decided to manage patients with conservative management when there was a large pneumothorax, and they were quite pleased and stated they were as good. So 316 patients were randomized, of which 154 had intervention, 162 were conservative. In the conservative management, 25 patients ended up having intervention, but they were looking at complete re-expansion by 8 weeks, which was achieved in 129 of the intervention group and 94% of the conservative group. So there was a case to say, look, do we really need to intervene in this group? And that's probably why our UK physicians have started to change. But the trial should be taken with a pinch of salt, because if you look at clearly, if you've intervened, they're going to be staying more, and the hospital length of stay is going to be more, as opposed to sending them home and telling, come back for a chest x-ray. But what was interesting is the recurrence was more in the intervened group rather than the conservative group, raising the possibility that this cohort was probably slightly different to what we would normally see. Because if you treat anything with a drain, then the recurrence is lower than not treating them. So this has had widespread criticism from the Western world, and clearly people are now thinking about cohort studies of managing it conservatively and collecting registry data to see how we get along. If it needs surgery, we do it VATS, is low conversion. You look for bulla and you staple them, and then you do a pleurectomy or TALC or pleural ablation. If it's secondary pneumothorax, look for lower lobes because they may have alpha-1 antitrypsin deficiency, and that may be the cause. So this is what you see. That's a nice big bulla in the upper lobe and the staples going across. And you can see it is a procedure which is done practically in every unit, with the guys in St. Thomas is doing the most. And where are we? Glenfield Hospital. We are somewhere in the middle. And if you look at the next diet of the 2010 to 2015, still it's the large proportion is done in guys in St. Thomas's. There are some units still doing it open, but that volume is reducing. And our incidence has again gone up. So in 5-year period, we've done about 400 cases. And the open interventions steadily reducing every year. And with pneumothorax surgery, there's a 99.5% success in survival with these patients. So it is an operation We used to do them with 3 ports. These days I do them with a single port, a 2 centimeter incision. You can do everything through one hole, and then they go home 2 days. You will follow them up. You will advise them about stopping to fly, and also not bungee jump or deep diving. Smoking cessation is important. This is just a few examples. So you may think this is an pneumothorax, but always get a cross-sectional imaging. That's a large bulla before you stick your drain in. A small hemothorax associated with a rib fracture, this could easily be just managed with a chest drain insertion. Large bulla, which may misguide you into a pneumothorax, be mindful. Cross-sectional imaging before any intervention. A big hemothorax with a drain, so hopefully the drain should relieve things. But when you have a complete whiteout with hemothorax, it's highly likely this patient would end up going to the operating room. Large pneumothorax, straight line, so drain, suction, re-expansion. Happy to take any questions. Thank you.